Dr. SRIKANTH, Professor of Ophthalmology in Mahatma Medical College, Pondicherry. He's my old student, friend, philosopher, everything is there.
Thank you, sir, for introduction. He is my mentor, and I owe everything what little I know to sir only. For many years, he has been trying to teach me, put something into my head. So after seeing ERG, we come to another mass response. It is another electrophysiological test that measures the resting potential between the cornea and the Brooks membrane during the light adapted and also in the fully dark adapted state. So that basically we are recording the positive and negative potentials between the anterior and posterior part. So recording is by placing an electrodes at the outer and canthus of the eye and one reference electrode in the center of the forehead. So the eye's pupil has to be dilated, skin electrodes are placed, and ground electrodes are placed in the forehead. This is how it is done, and the patient is asked to move the eyes either way, towards the right and also on the left. So when the eye is moving towards the outer side, it becomes positive for on that side and negative to the right side. For example, he is moving the eyes towards the left. So the electrodes on the right will show negative potential, and that on the left toward the eye towards which it is moving will show a positive potential. So this basic difference we are recording and saying whether the response is, the ratio is normal or abnormal. So basically this again detects the mass response only. So the dark adapted phase has to be there. The eye is dark adapted for minimum 15 minutes. Then again the recordings are done, and again light is exposed to light, and in the photopic condition again the recordings are done. So this is how it is done. So you measure the amplitude, you measure the time latency between these recordings, and that is given in a chart. So this is what I told. The closer electrode to the cornea becomes positive, and electrodes in the opposite side becomes negative. So here the care has to be taken. Two things are important. One is dilatation of the pupil. Second is the dark adapted state, whether it is properly done or not. And while moving, the eyes only should move, not the head. So you can see in this picture how the electrodes are kept and how the eyes are moved in each direction. So we see what is the light peak and the dark trough. Light peak is the one which is the maximum peak of the waves recorded at during the light exposed phase. So this results from the movement of intracellular calcium released from the endoplasmic recording reticulum. So this patient is exposed to light, and peak amplitude is reached by 7 to 12 minutes. That is known as a light peak. So here the picture shows pointer. So here you can see. Here you can see this is light on phase, 15 minutes. Then lights off, light on. You can see the light is on. This is movement when the patient is looking towards the right. Then movement when the eyes are looking towards the left. Like that it goes on, and the light peak is reached, say, by 10 to 12 minutes. Same way when the lights are off, after 15 minutes of dark adaptation, you see this. Eyes are moving out to the right, looking to the left, like that. So this is the dark trough. This also comes, say, by 10 to 12 minutes. So this ratio is what is famously called as the Arden ratio. Earlier it was called as the Arden ratio. Now, now these recent standards, we just measure where is the light peak and amplitude and time to start. All these are taken. So variations can happen if the pupil size is not regular on both the eyes. Deviation from the standard protocol can result in variations of these recordings. So again, this is again a mass response which you will get when the RP is photoreceptor complex is affected. So this is not you cannot differentiate whether this is due to this or that. So this is you can see the difference where ERG may be normal, but the EOG may be abnormal. So this is what you can see in this. So reduced thing, EOG, ERG is normal, used in this macular dystrophy, best macular dystrophy. Even before the classical picture is seen, you can pick it up by this. Usually these tests are done when you don't find anything really grossly abnormal, but the vision doesn't improve. So these are the tests where it is not a routine test. When we have difficulty in diagnosis, then these things are used. So autosomal recessive reduced light rise is seen. So here mildly reduced rod and cone response. So here it is normal. Here it is normal. So like that, this is how these are used to differentiate between the place of the lesion and the type of dystrophy. So these are all few diseases where there is an abnormal EOG with normal ERG seen in Best disease, fundus flavimaculatus, as sir told, also in chloroquine retinopathy. So abnormal EOG you can see in Best disease, Stargardt's disease, retinitis pigmentosa, chloroquine toxicity, siderosis bulbi, and in vitamin A deficiency there may be a flat EOG, and CR vivo ischemic there will be abnormal light peak. So these are the things which is seen. You can see the normal EOG with dark phase at 12 minutes and the peak phase again at 10 to 12 minutes or sometimes 8 to 12 minutes, and you can see this reduced dark phase as well as the light phase. So here again hydrochloroquine toxicity, you see the value, Arden value is 1.48, 1.36. Whatever it is below normal, that is 1.8, is considered as something abnormal. So here again a normal subject, dark phase and light phase. Here it is reduced, seen in cases of retinitis pigmentosa. The light phase again is decreased. You can see here. So special thanks to my mentor who had included me in this instruction course. Thank you so much, sir. Any doubts? I'll be.
These slides. How will you make out that the light phase and the
You have to.
dark phase? How do you make
This one?
these charts?
This one? This one?
Yeah. How will you make out the dark phase?
This is dark phase. Wave is not there, but represented in a different way. This is the normal one, but represented in a different way.
this, how do we make out
Here both the things, both in the dark as well as light phase, both it is depressed. Yeah, value. That value is not. Yeah, that it is not in a wave pattern. That's what I think you mean. Instead, it is represented in this way as dots.
yeah, this I can make out should be like this. It's
Yeah, this is like this.
make out that
Yes.
just after.
So the compare it with this, it is abnormal. That's all. Here you can see the Arden ratio when it is given. Then you will be able to make out that it is an abnormal thing.
Actually, we try to explain something, and ERG and EOG, and which normally we don't see. Most of the patients, some institutes, they can have ERG machine, may not be working. It will be lying somewhere, and some institute will be working. And now, actually, I started learning ERG when I was in RIO Chennai, Regional Institute of Chennai. There also ERG machine was not working. So we used to refer the patients to know something. I used to refer the patients to Shankar Nethralaya there. Then I used to get a report. Then only I came to know ERG is like that. So many things are there. We can easily interpret so many things in ERG. Now, basically, what you're supposed to know is, if you want to know the functions of rods and cones, ERG is better. Functions of pigment epithelium, if you want to know, EOG is better. If you want to know the optic nerve and other areas, VEP is better. VEP also same thing only. We get our recordings. One is on the forehead, is called Z point, the central point of the forehead, central point of occiput, and then we got a earlobe reference. So one is positive, one is negative, one is it's called same VEP. Just like EEG, the record. They put what they do, record here one central point forehead, occipital lobe one forehead. This is what a normal VEP. When you apply flash is going to fall on your retina. The impulse is going to be is going to my brain, occipital lobe area. It's going to be recorded. Now they will find what? How many milliseconds it takes for the maximum amplitude to come from this flash. They will have values and all. They will have waves. It's called positive 100, P100 or positive 135. Like that they give numbers. So P100 means what? The positive wave. N75 means the negative wave. The maximum N75 after 75 milliseconds, the negative wave has to be maximum. After 100 milliseconds, the positive wave has to be maximum. They have given everything. So the positive P100 is there. If it is, suppose the positive is coming after 150 milliseconds, that means the problem is prolongations. Some conduction pathways problem is there. Latency. The time taken for the maximum amplitude. The P100 means a latency. The P100 wave, normally after so many milliseconds, it comes. Now, if it is 125, that means what? 100 to 120 is prolonged. That means the time taken for P100 to come is 125. That means prolonged latency.
What is the reference?
They will give values. The paper itself will be there. P100, the number will be there. P100.
But what values should be taken as normal?
Normally, after 100 to 120 milliseconds. 100, because your impulse, I'm standing in front of you, I am falling in your retina, and I'm going to reach your occipital lobe. It takes minimum 124 milliseconds. 124 milliseconds, that's the normal time from ganglion cell to your occipital lobe area. That is what you are going to record. But actually, it's maybe 100, 125, so many things are there. Just know if it is prolonged, latency is prolonged, conduction problem. Now I know amplitude. Amplitude from baseline, you are going to measure. The amplitude reduced means what? Ischemic problem, that's all. The pathway is suffering. The ischemic problem is there. It's not allowing the amplitude based on the function of that area. If the function is not working because of ischemia, naturally the amplitude reduced. So,
We often give a report saying probably of demyelinating.
Latency is prolonged. Probably deblooding problems. Amplitude reduced. Maybe a case of that area occipital lobe problem is there. Maybe a tumor. Maybe ischemia. Like that you can tell.
So that means the P value will increase. Instead of 100,
P100, the P100 value
that will increase.
increase.
What is telling the
If it is incremental problems, it's optic neuritis, classical. If it is P100, amplitude is about something is there. Is coming down. That means some ischemia is going on in that area, in this visual pathway, and it may be anywhere.
300 could also increase, say, in a glaucomatous activity. We think that affects.
No. P100 ischemic problem, it will be decreased. It cannot increase. Latency can be prolonged, means it's a myelin sheath problem. It's mainly the myelin sheath is the conducting element. Myelin sheath, demyelinating problems, the myelin sheath is a conducting element. It's not the axons. Axons are all just taking for your functions, that's all, mitochondrial transmission, all. The myelin sheath is responsible for conduction. That's why you got a RAPD. Why? Demyelinating problems. The conduction light is delayed. RAPD is because of demyelinations. It's not because axon means your visual problem will be, the visual acuity may be reduced.
Is there a chance that a test may be inaccurate for the way it has been done? That we need to see a quality score or something?
The computer itself is a message, is impression is good. The computer, they've got machines. It will give you correctly.
So there are some cases there is confusion between optic atrophy. What is the cause of optic, also whether it is demyelinating disease or glaucoma. So there must be some confusion. So how to delineate such cases with the
Glaucoma is an ischemic problem. Definitely amplitude be reduced. See, if you want to know the full area of the visual pathway, you have got a multifocal EEG. They will have electrodes here, one electrode, 3 electrodes in the occipital lobe, the parietal lobe some area, and frontal lobe. Everywhere the electrodes will be there. That means they have to find out the entire visual pathway. What VEP are going to see maximum up to chiasma. That's all. If you want to see the tract and all, you have to go in for multifocal. Multifocal VEP is there. Then only can tell you, albinism patient is there. Albinism patient, oculocutaneous. They will have more amount of crossing fibers. That you can easily find out multifocal.
beyond chiasma, then we have to mention
Multifocal. If you want to know, I want to know my LGB, whether it's working or not, I want to know this multifocal. Because your VEP normally maximum chiasma, that's all. Maximum. Even optic nerve only maximum, we can tell you. Whereas chiasma and above also something you need a different VEPs. Multifocal.
So usual VEP is up to chiasma.
Ordinary VEP.
Ordinary VEP.
Maybe up maximum up to, that's all. Because chiasma also very difficult to me, because crossing is there, they will find it difficult. So, understand? This is what, and one more very nice inference, we got a pattern VEP is there, not light, like a ERG pattern, no? I can tell you the macular functions and all. This pattern VEP, suppose they put in your eye, it takes about 100 milliseconds to reach, I get a maximum amplitude. Suppose normal, you are a minus or something. I put without glasses, I put a light. I have some impulse. Now I am not getting a maximum amplitude. Now I put a glass. Now it's going to be focused in the macula. I get a maximum amplitude. Now I can indirectly find out your power as well as whether you are myope or hypermetrope. Even your refractive status also you can find out the VEP. That's the beauty of VEP. But mainly pattern VEP, not flash.
Usually what we do is flash VEP.
Normal, all VEPs you do. Pattern VEP, that is called on-off, so many things are there. Checkerboard patterns, pattern reversal. Then we got ordinary flash VEPs. Then we got on-off phenomena, something like that. We got different.
That also gives some flash light.
Flash means checkerboard. Checkerboard is there, no? Like a chessboard. Black is there. Black for 2 seconds. And that black will become white. Again, that's called pattern reversal. Pattern reversal VEPs.
Like
ERG only. Pattern reversal VEP.
The pattern reversal will give us more information.
More information about the macula and all, definitely. Because with the macula only you can tell you this pattern. Pattern VEP itself, pattern reversal only they put. They will not only a pattern, they will keep on reverse it.
That will give us
More information about your macula, that conducting pathways, that's all.